In the landscape of cancer disparities, few patterns are as stark and as urgent as the disproportionate impact of obesity-related cancers on minority communities, particularly among non-Hispanic Black populations. While obesity is a well-established driver of multiple cancer types, the intersection of race, socioeconomic status, and structural inequity compounds its toll in communities already burdened by limited access to care and higher baseline health risks. The result is a public health emergency that is both biologically and socially determined, and one that continues to grow, largely unaddressed, beneath the surface of national cancer statistics. Non-Hispanic Black individuals, especially women, experience significantly higher rates of obesity than other racial or ethnic groups in the United States. According to the CDC, over 56% of non-Hispanic Black women are classified as obese, compared to 42% of non-Hispanic white women. This elevated prevalence of obesity is not simply a matter of individual choices. It reflects long-standing structural disadvantages, including food deserts, income inequality, targeted marketing of unhealthy foods, fewer safe recreational spaces, and chronic stressors such as racism and financial insecurity. These environmental and psychosocial factors drive up obesity risk and make sustained weight loss far more difficult to achieve. But obesity in these populations does more than increase the risk of cancer development. It sharply elevates the risk of cancer death. Non-Hispanic Black populations suffer from disproportionately high mortality rates in several obesity-associated cancers, including colorectal, endometrial, pancreatic, liver, and postmenopausal breast cancer. These disparities cannot be explained by biology alone. They are amplified by delayed diagnoses, limited access to specialized care, underinsurance, and differences in the quality and consistency of treatment received. Endometrial cancer offers a particularly troubling case study. Black women are more likely to die from this cancer than women of any other racial or ethnic group, despite having similar or even lower incidence rates. A significant portion of this mortality gap is attributable to the more aggressive subtypes of endometrial cancer that occur more frequently in Black women, subtypes that are strongly associated with obesity and metabolic dysfunction. Moreover, Black women are more likely to be diagnosed at advanced stages, less likely to receive surgery or radiation, and more likely to experience treatment delays. The role of obesity in driving this cancer, and in compounding its severity, is both profound and underacknowledged in clinical and public discourse. Breast cancer follows a similar pattern. While overall incidence is lower in Black women compared to white women, mortality is significantly higher. Black women with obesity are at particular risk of developing triple-negative breast cancer, an aggressive and treatment-resistant form. Postmenopausal weight gain, especially in visceral fat, increases estrogen production in fat tissue, fueling hormone-sensitive tumor growth. Yet systemic barriers, such as lack of routine screening, miscommunication with healthcare providers, and lower rates of timely follow-up, mean that Black women often face later-stage diagnoses and poorer outcomes. Colorectal cancer is another area where the obesity cancer link is particularly devastating. Black Americans have the highest colorectal cancer incidence and mortality rates of any racial group in the U.S. While diet, obesity, and physical inactivity are key modifiable risk factors, these are deeply shaped by unequal access to fresh food, safe environments, preventive education, and healthcare services. Early detection through screening can dramatically improve survival, yet screening rates remain lower in Black communities, and even when screening occurs, diagnostic delays and differences in care persist. Importantly, these disparities are not due to lack of awareness or concern within affected communities. Many Black patients report high levels of health consciousness, but face systemic obstacles that prevent consistent care. These include provider bias, lack of culturally competent care, historic mistrust of the healthcare system, and practical challenges such as inflexible work schedules, transportation limitations, and underinsurance. Obesity stigma adds another layer of harm. Patients who are overweight or obese may experience dismissiveness or blame in clinical settings, discouraging them from seeking care at all. Current cancer prevention efforts have largely failed to integrate obesity and racial equity into a unified strategy. Public health campaigns often lack cultural sensitivity and do not explicitly address the compounded risk that obesity poses for minority communities. Meanwhile, cancer research frequently underrepresents Black patients, especially in obesity-related studies, leaving critical questions unanswered about how weight, race, and cancer interact biologically and socially. Without focused investment in understanding and addressing these disparities, interventions will continue to fall short of those most at risk. To reverse this trend, solutions must be as layered and intersectional as the problem itself. Health systems must expand access to affordable, community-based obesity and cancer prevention programs tailored to Black populations. This includes culturally specific dietary guidance, safe exercise initiatives, mental health support, and education on the obesity cancer link. Screening outreach must be intensified in high-risk neighborhoods, with efforts to reduce logistical and emotional barriers to participation. Medical providers need training in anti-bias practices and greater accountability for delivering equitable, evidence-based care. The fight against obesity-related cancer cannot be won without addressing the racial disparities that fuel its deadliest outcomes. Non-Hispanic Black communities are bearing a disproportionate share of preventable cancer deaths, not because of biological destiny, but because of a failure to confront structural inequality in health. This is a call to action not just for cancer researchers or obesity specialists, but for every sector that touches the lives of vulnerable populations: urban planning, food policy, education, and economic development. Until these systems are reshaped to support health, the most marginalized will continue to suffer the highest costs of neglect.